All right, good morning, everyone. I am Siobhan Martin, Chair of the Pebb Board, and I am calling to order the August 16th, 2022 Pebb meeting. And I am going to start with a roll call to see which board members we have with us this morning. So Jeremy Vandehay, are you here? Not sure Jeremy's joined us yet. What about Greg Klauser? Don't see Greg either. Andy Foltz is not here this morning. She is excused. Kimberly Hendricks, I see you.
Good morning. I'm here.
Good morning. Dawn Mottner. Dawn, have you joined us yet? I don't believe Dawn has joined us yet. Kate, you are here. I see you. Good morning.
Good morning.
And Sean Parkman, I see you as well.
Good morning.
Good morning. And I want to welcome Representative Rob Nose. He is joining us as one of the legislators on the Pebb board. So welcome, Rob. I understand that you have served on this board many years ago.
I've been around Pebb since 2013.
Yeah, great. And we actually are not going to move immediately to the first order of business, which is approving our minutes. So I would like to give Representative Nose a moment to introduce himself.
Well, thanks, Siobhan. I think I actually know a lot of you. So I represent in the legislature House District 42, which is inner southeast and a little sliver of inner northeast Portland. I've been serving in the legislature since 2014. I was on the Pebb board officially for a hot minute, like 6 months, when we did a request for proposals to redo everything. And that was pure hell, to be totally honest with you. So, but I learned a lot, and I think it probably ultimately benefited me in the legislature when I began serving in 2014. That's when I had to step off. I've been on some of your work groups and committees, schedule permitting. I've popped in and out periodically on different things. So I feel like I'm very familiar with Pebb and the benefit design and the challenges that we have and the innovation that we're pursuing. I'm delighted to be here, and that's probably enough. I'm also Democrats, if they retain control of the legislature, I'm likely to be the chair of the healthcare committee in the 2023 session.
Thank you, Representative Nose, and really appreciate you joining us on the board. So, Rose, if you can just chat if you see another board member come, and at some point we may go back to approving the agenda, and if not, we can do it at the next meeting. So I am going to go ahead and move us to the COVID landscape update, and I believe we have Kaiser reporting first.
Hello.
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 Should I turn it over to you, Safari?
It's Greg.
Oh, Greg, you're here. Great. So actually,
Yes, it took everything I had to get here. I am in Jamaica.
Oh, my goodness. Well, you're joining us on
here.
your vacation. Thank you.
I am. You're welcome.
So before, so actually, if you can give me a minute, Sapari, I'm going to go ahead and have us approve the minutes first, since we now have a quorum. Do I have a motion to approve the July 19th minutes? And actually, do you mind, Rose, going backward so we can go back to the minutes and get that business done? So I do need a motion to approve the July 19th, 2022 minutes.
So moved.
Thank you, Sean. And do I have a second?
I can second if you need, Greg.
Thanks, Greg. So I have a motion and a second. All right. So we have 2 votes from the motion and the second. Kate, how do you vote?
Well, I wasn't there, but I'll vote yes if everyone else agrees.
All right. You can abstain. That's fine. But I'll.
Well, don't you need me? Yeah, go ahead and do yes. It's fine.
Okay. Thank you. I've reviewed them. We've reviewed them, those of us who were there.
I always feel weird voting on this when I wasn't at the meeting. That's all it is.
All good. Kimberly.
Yes, I'll vote yes. Thank you.
And I will also vote yes. So the minutes are approved. Thank you. All right, let's go back to Kaiser's presentation, and I'll give it over to Sapari.
Perfect. Thank you so much for having us this morning. Our presenter today is Dr. Mary Giswald. She is the Chief Operating Officer of Northwest Permanente. And our presentation for you is geared, on the COVID landscape, but really towards our a lot of what's happening with our care delivery. Please feel free to ask us any questions at any point during this presentation. We welcome the discussion. So with that, Dr. Giswald.
Thanks, Sapari, and thank you all for having me here. I'm happy to share our update. So I think in the interest of time, I'll just jump right in. We're going to talk a little bit about some trends. We'll talk about vaccines and testing, and then I want to focus most of the conversation around the impact of the pandemic on care, deferred care, and access to care. So next slide, please. As I think many of you all know, we've been through multiple surges. Obviously, the most impactful surge was the Omicron surge early this year. And now we are, starting to come out of this smaller surge for BA2 and BA.5. During Omicron, we had over 200 KP members hospitalized. Now it's less than half of that right now in terms of KP members that are being hospitalized right now with a diagnosis of COVID-19. Next slide. This is a bit of an eye chart about vaccinations, and as many of you probably know, there's a lot of complexity around vaccines, who's eligible, what the doses are, which combinations of vaccines. I think my message is there is a lot of complexity here. We in KP follow very closely to CDC and ACIP guidance. And the good news is that vaccines are widely available in KP for all members. We have vaccinations both on an appointed and walk-in basis. Next slide. And as you can see, here's our the vaccination rates for Pebb and for our commercial line of business across the board. And, really, Pebb's doing great, 76% vaccination rate, and then almost 65% vaccination rate for people who have had additional boosters. So, making good progress there on vaccines. And next slide. Oh, back up one, please. There we go. Testing, widely available. We have PCR testing at multiple sites across the region. Currently, the turnaround time for a PCR test is about 24 hours. And we are seeing overall that people are doing less testing. I think with the rise of the home antigen test, people are doing a lot more testing of their own at home. So it gets a little harder for us to track the data around percent positivity rates because we're not really sure. The numerators and denominators of today are probably not the same of what they were before the home antigen tests were widely available. But we do, we still have PCR testing widely available for people who, we really want to make a confirmatory diagnosis to offer treatment, or B, because sometimes people need it for some sort of event or, previously for travel. And next slide. So, regarding deferred care and the impact of the pandemic, the pandemic really has left the healthcare system right now in a pretty fragile state. And Oregon and Washington have the lowest number of hospital beds per capita in the United States. And the demand on our hospitals for both COVID and non-COVID related care is high. And we're still really seeing persistent high demand on the hospitals and on our EDs, even as the COVID census has come down. And while we're seeing that higher demand, we're also struggling with staffing. There just are not enough healthcare workers right now in Oregon and Washington to meet the demands. And that is causing longer wait times for care across all healthcare venues. And, all of the systems, we're all competing for the same workforce amongst doctors, nurses, CNAs, medical assistants. And we do have some backlogs related to the moratoriums that came in and, that came and went through the various surges. So we do have some backlogs. And we are seeing increased demand for services across the entire system, whether that's in primary care, urgent care, hospitalization, and also in mental health. Next slide, please. So as we're coming out of this, we're really having to look at how we do things differently and, revisit some of our care models that we had pre-pandemic and evolving them to this new era where we have high demand, we have a strained workforce, and we have backlogs for care. We did in KP during the pandemic, we built a home hospital program where we now are hospitalizing about 15 to 20 patients a day in their own homes, where we bring essentially the hospital to them in their houses. And we're seeing really great quality patient satisfaction with that program. We also, in the beginning of pandemic, there was a huge increase in the use of telehealth. And now, and during that time, we also built up programs like we have what we call Get Care Now, which is an on-demand video urgent care. And then also e-visits, which are a algorithmic-based type of care that helps guide care. And then soon we'll be doing chat with a nurse. But I think what we're seeing is we have built those things and we're offering those things as choice when it's clinically appropriate. But we are seeing patients wanting to come back to the clinics for more face-to-face care. They want, and our clinicians also want that relational care where there's, people are getting in to see their primary care doctor to get that type of, because a lot happens in that relationship between the patient and their doctor that can't always be captured in telehealth. So we actually have seen our telehealth numbers have actually come down quite significantly in 2022. Next slide, please. So I want to say a little bit about mental health. We have seen a significant increase in demand for mental health year over year over the last couple years. And, it's across the country that, more people are experiencing depression, anxiety, severe mental health issues, substance abuse issues have increased dramatically during the pandemic. And we are trying to move quickly to help meet the needs of people who need mental health services. As you can see here, even within Pebb, we're seeing an increase in need for mental health services. So we're doing a lot of hiring. We are onboarding new therapists as quickly as we can hire and get them on board. We're doing things to simplify the appointing process for people who are seeking therapy, really taking down any barriers to pre-approval so that if someone thinks they need therapy, we want to connect them and get them the help they need. We have a program where we have integrated behavioral health counselors, so we call them BHCs, and these are therapists where we have embedded them into all the primary care clinics. So instead of having to go through specialty mental health, right there in the moment, our primary care clinicians can connect a patient to a BHC to get going on some counseling right away. And we found this program to be very, it's very effective in getting people care faster. And it also helps us manage the referrals to our specialty care mental health department so that we have that specialty care psychiatry services available for people who have more advanced psychiatric illness, and that for people with more what we call primary mental health issues, so some depression, anxiety, we can meet their need quickly. Okay. We also, next slide. We also have added a few additional kind of wellness coaching and app-based mental health options for people. We're using a platform called Ginger, which offers wellness coaching. It's one-on-one support for anxiety, stress, issues related to work, relationships. And the coaches are there 24/7, and all adult KP members can use the app for 90 days per year at no cost. Now, it's not a crisis line, but it's more of like just a support system for people. And okay, we're working also in the mental health space on just pipeline development, because really there are just not enough mental health providers out there. We're getting involved in exposing younger people to mental health career paths in high school. And we want to help fill the pipeline with compassionate, ethnically diverse, multilingual clinicians who are there to take care of our members. Next slide. I want to talk a little bit about primary care. As many of you may know, there is actually a national and a shortage in Oregon of primary care doctors and clinicians. And we, we know that adult primary care is a really challenging job. It's gets more and more complex all the time as we bring in things to help with the more lower acuity issues. Our docs who are seeing patients in the primary care clinics every day are seeing more and more complexity. So we are working with our clinicians and our physicians to enhance their retention and the recruitment. And we want to have clinician positions in KP where people want to practice primary care for many years. Because really the benefit of primary care is that long-term relationship between a patient and their primary care clinician. The fact that they know each other, the physician can really understand the needs of the person. And so we are doing some internal work around making that job more sustainable, bringing more resources to the paneling clinicians through our BHC model, through what we call dyad support, making sure they have a consistent medical assistant that is their partner, that they help manage their panel of patients with. And, we all in KP have been on really on a journey about social determinants of health over the last few years. And this year we are working on making sure all of our patients are getting screened in their primary care clinics for social determinants of health. And then when we identify a gap in their social determinants, we can connect them through our community health workers to the resource access specialists, connect patients to CBOs, because certainly one of the barriers to health is being able to get to your appointments, being able to pay for your medications, being able, frankly, just to navigate the complexities of even our own system. So we are really proud of that program, and are committed to making sure that we are helping our patients address their social needs. Next slide, please. In urgent care, like many other areas of our care delivery ecosystem, we are seeing a sustained high demand. Normally this time of year, we start seeing the urgent care volumes go down. But this year, especially over the last 4 months, we have seen 10% higher demand in urgent care than we have in previous years. And, while that's happening, there aren't always more staff, more doctors, more nurses coming to help us take care of those patients. So we, have really a grassroots project going on in our urgent cares right now. And so far, we are seeing about a 25% reduction in wait times at our pilot site at Urgent Care, where they've really just redesigned how they do the work, how they bring patients in, And their goal is really to get the patients in front of a physician or a clinician as quickly as possible and move the patient through the visit in a efficient manner so that people aren't spending 2 hours, 3 hours in urgent care. And so far, we're seeing great engagement from our teams. We're seeing some early, really great feedback from our patients. And I think, to me, this is the type of project, this is the kind of work that we are really digging into in 22 and into 23, where we're looking at just across our system how we provide care, because given the demand and the changes in our workforce right now, we can't do things like we did in 2019 and expect to get the results that we want for our members and our patients. Okay, next slide, please. So I'm sure many of you have been hearing about monkeypox, and that this is kind of the newest thing on the horizon that really descended on us in July. There are, as of when we made this slide, 72 cases in Oregon, 154 in Washington. The good news, monkeypox does not pose the same threat to the staff and to our members as COVID-19 did. But, some of the things we learned in COVID are really helping us move quickly to implement and scale our response. Monkeypox is not contagious before symptoms develop, and the majority of people who get monkeypox will recover uneventfully. There are vaccines and there are antiviral treatments for monkeypox. We currently in KP are offering vaccinations. It's a self-referral for eligible patients. And I think as of end of last week, we had vaccinated about 100 people in Oregon and another 50 up in Washington. We offer the vaccination at multiple sites across the region. And there was a recent change in how the vaccine is administered that we put into place this week that is going to significantly extend the supply of the vaccine. So, we have a team working on this, and so that we're ready to, help our patients who are either exposed to or develop monkeypox. And I think that might be the end. Next slide. Yes. So we're happy to take any questions that you all may have.
Right. Do any of our board members have questions for the doctor?
Just to follow up on vaccine availability related to monkeypox, what is the eligibility that KP has for access to that at this point? And is that universal or is that particular to KP?
No, we follow the standard CDC eligibility guidance and the ACIP guidance. And I think the vaccines, Keith, you might have to jump in and help me on this one, but eligible criteria is, I think, people who have been potentially exposed or who may be exposed. But we don't, our patients can just go in through the kp.org website or call, and if the patient, it's a kind of a self-screening type thing. Keith, you're on mute.
So some of it's being done through HIV clinic, which is catching people at highest risk who have HIV and other risk factors. But it is self-attestation. There's probably some people who are not the highest risk who will be getting it, and we're aware of that. So it's a little bit less probably guided than initially COVID was. But we think this meets the recommendations of the CDC, and we'll get the services out to people who need that as the availability of vaccine goes up.
Thank you both. It looks like Representative knows your question was answered. Is that right?
Yes, it was.
Right. Thank you. Ali.
Thanks, Siobhan. Just wanted to mention that DCBS just issued a notice that requiring insurers to cover monkeypox vaccines. So we are starting to work with the carriers on how we roll that out, and so more to
Yeah.
come on that.
Not a the big deal right now is just the supply of the vaccine. All vaccines that are recommended are covered without cost share. So the issue now is just getting adequate supply of vaccine and a rational distribution as well.
Thanks for that update, Ollie. Any other questions folks have? All right, thank you so much.
Thank you.
All right, I believe we're going, Erica, we have someone speaking from MODA, right? We have Dr. Popowich, is that right?
Yes, you said that.
All right,
just right.
welcome. Thank you.
Thank you. So good morning, and thank you for this opportunity to look a bit back at where we are in this partial sort of lull in the post-COVID world. I'll be speaking today about some observations on the Oregon provider landscape, the effects of inflation that we've seen so far, and implications of long COVID that we've observed so far. I'll then turn things over to my colleague, Bill Dwyer, who is going to discuss a more detailed look at the COVID impact on actual utilization from our experience. I realize some of this information will overlap with that already presented by our colleagues at Kaiser, and that will be presented by Providence, but hopefully will still be of use and illustrative and another perspective. And in the interest of time, I will be skipping over a few slides, but they are in your packet for review. So I'll start with this slide, the Oregon provider landscape. You know, it's been no surprise to anyone that the impact COVID has had on staffing challenges throughout the state. This has had a cascade effect touching on many different areas. When it comes to actual staffing, this is widely documented, affecting everyone from front office staff to actual caregivers, be that nurses or MDs, and has left, many have left the profession due to the stress of COVID and overall burnout with what they've experienced. Deferred care during the pandemic, which I'm going to talk about later, has led to exacerbation of conditions, which is creating a demand for healthcare that's outpacing supply at the moment. In terms of how it's impacted financial struggles, this is particularly seen in the hospitals due to inflation and labor costs, putting further pressure on hiring and hours of operation. Requests for much higher rate increases than normal is something we're observing with contracting in our provider relations department. When providers and hospitals are coming to renegotiate contracts, they're coming in with requests that are much higher than we have normally seen, and that's understandable given the impact COVID has had upon them. And there's generally been provider unwillingness to engage in anything that's not direct patient care right now, since areas like VBC, data analytics, and back office staff are areas that can be put a bit on the back burner without impacting care. So let's skip the next two slides. The next slide is also about the provider landscape, but we can skip that. Yep, skip that and then skip the next one as well. And I'm going to jump right into inflation. And this is also, you know, no, go back one. Sorry. Yep, thank you. So inflation, you know, this is obviously a very hot topic throughout our entire economy, but what we're seeing in how it is affecting providers and systems, that it's been exacerbated depending on the payer mix of hospital and providers. Older patients are driving a higher cost profile, but there are more stable changes because their costs are already high, so the percent increase is smaller. Healthier patients who only use primary care services are a lot of people, but they're a relatively small part of the total cost of care and will have slower cost growth. Any advanced technology from drugs to implants, including those providers who use or supply them, will have a higher cost trend. And smaller, more likely rural hospitals are going to bill now on more of a percentage of costs. And tied into that, they're going to have larger charge master increases than hospitals that already have in place bundled services or reimbursements that are tied to a percentage of Medicare. Next slide. So I'm going to jump into implications of long COVID. These are some quotes that I found recently that I thought were very illustrative, because I don't really think people are appreciating what the impact and effects of long COVID will be. The New York Times Magazine had an article less than a month ago, Endemic COVID could be brutal. Much more extensive article, but that was kind of a salient sentence that jumped out. And then even more recently, 4 million full-time equivalent workers are out of work because of long COVID, 2.4% of the US working population, which is a tremendous number. Next slide, please. So implications of long COVID. Long COVID may be a disability under the Americans with Disability Act, and as such, employers are going to have to respond accordingly and provide the right accommodations. It's an ongoing urgent topic of discussion. Well, before I go into that, estimates of the proportion of people who have had COVID-19 that go on to experience post-COVID conditions can vary, but overall it's accepted that about 13% at 1 month or longer after infection, 2.5% at 3 months or longer based on self-reporting, and more than 30% at 6 months among patients who were hospitalized with COVID. Common things that we see are things like loss of hearing, skin changes, calf pain, dry eyes, rashes, confusion, brain fog, loss of taste and smell, abdominal pain, lower back pain, muscle pain or weakness, tinnitus, chest pain, depression and/or PTSD, fibrosis and scarring of the lungs, cognitive impairment. The list kind of goes on and on. Next slide, which we'll skip because that's just more symptoms. Next slide. So this is important that when it comes to chronic disease and COVID, people with chronic disease already are a disproportionate part of overall health costs. Their conditions are expected to become more severe if they've had a diagnosis and will have an outsized impact on overall health costs. What was generally accepted before as the 5% incurring 50% of costs, some analysts predict that could go up and become the 570 rule, but we shall see if that actually comes to fruition. Next slide. So the public health emergency in itself caused deferred care. This impacted screenings, childhood vaccinations, surgeries, mostly musculoskeletal, and miscare that exacerbated existing diseases, things like diabetes, chronic kidney disease, cardiac issues. What's really interesting here is there has been less information about the extent of missed routine pediatric care. In March of 2020, pediatric outpatient care visits declined by 70% for children under 18, and that pediatric visits remained below pre-pandemic levels by October of 2020. Data also showed that from March to May of 2020, 500,000 fewer US children received blood level lead screenings, 10,000 of whom may have had elevated levels requiring interventions, as well as highlighting concerning gaps in vaccination coverage. These data are suggestive of significant and potentially harmful disruptions to routine pediatric preventive care as a result of the pandemic. The belief is that it will catch up as quickly as the system can handle it and as people feel safe and comfortable going back to their providers. Next slide. So we're all aware of the impact that the public health emergency had on various things, but mental health is probably one of the biggest. And I know our colleagues at Kaiser mentioned this. This has been very important for us as well. These impacts were particularly sharp in the under 30 population. And interestingly, it was also observed that alcohol use in women in midlife increased dramatically over the public health emergency. Things affected were disengagement, acedia, focus issues, isolation, substance abuse, depression, and suicide. To illustrate that, next slide. So behavioral health compared to pre-pandemic levels, there are 3 times more individuals reporting symptoms of anxiety and depressive disorders, close to 3 times more individuals reporting suicidal ideations, a 30% increase in drug overdose deaths, and a 50% increase in the number of individuals with a behavioral health need. And in addition, the increase in behavioral health needs is disproportionately impacting racial and ethnic minority groups by a factor of 1.2 to 2 times. Next slide. This is, I believe, my last slide. So, summary, the Oregon provider landscape adaptation recovery will be closely watched for all the factors I already spoke about. Inflation remains a deep concern, but perhaps after some of the news we've gotten this past week, the news may be good. Long COVID could have devastating clinical consequences, and we're going to have to keep monitoring this very closely. The costs of long COVID, there will be a rebound in deferred care, but how much remains to be seen. There will be consequences of untreated chronic disease and undiagnosed acute diseases, but how much is still yet to be determined. There will be increased mental health costs, and the increased prevalence of these issues will conflate with other costs, mostly because if someone is depressed, severely depressed, that can lead to the exacerbation of other chronic conditions. And people with long-term unresolved post-COVID issues, either from the virus or for a decline in a condition, will be costly. And again, how much so, we will just have to continue monitoring closely. So with that, I'm going to turn things over to Bill Dwyer, our Director of Analytics, to talk about the data more specifically and utilization.
Thanks, Dr. Popovich. Hi, everyone. So I'm Bill, Director of Analytics at MODA. I've got some slides here that delve specifically into the Pebb utilization data and also some broader utilization data that we thought would be interesting to show. So we've seen and heard a lot of discussion about some of the macro trends, but we wanted to show you exactly what we're seeing in our data. And so this next section is just Pebb members data. There will be some web data as I've noted it, but I decided to use a creative time period here to really separate out 3 years, the pre-pandemic year, and then in the first year of the pandemic and the second year of the pandemic. So you can see there the date ranges that make that convenient. And just to note, this data is not risk adjusted. So let me just jump right into it, and we'll go to the next slide. So I put the eye chart first, so that you could just get used to this right away, since this is a bunch of data heavy slides. As a spoiler alert, so this is the one that has the most numbers on it out of all the slides, so hopefully you can indulge this one. Anyway, what you're looking at here is a chart the way we often will look at our utilization data that breaks it down by category and subcategory. So in terms of the columns of numbers, those black 3 columns there, the allowed per member per month cost, and then the purple numbers on the right, that would be the count of services per 1,000 members per year. And a bunch of things jump out at you when you see this. Actually, if we just look at the grand total at the bottom, you can see that we had 2019 was like, if you look at the per member per month cost, so it went from $524 and then dropped considerably in 2020 and then rebounded in 2021, even to a higher level than what we saw in 2019. Which, and so everybody, that shouldn't be any surprise to anybody in this discussion, because we know that the COVID pandemic depressed utilization in 2020, and then a lot of the utilization came back in 2021. In particular, when you look at some of this data, you can see, and by the way, I'm going to mention a few things on this chart, but then my next slide actually has a summary of bullet points of what I'm about to say, in case you forget or want to look at it later. But anyway, if we go up to the top at the inpatient row, you can see there what's happening on inpatient is we've got emergent cases, and then we have elective or non-emergent cases, and you can see that the non-emergent is where we had a decrease and it continued to decrease, which makes sense. People deferring things that are not an emergency, and that trend holds true throughout this chart. When you look at a bunch of this other stuff, you can see that, for example, the emergency room, it was high, it dipped in 2020, but then it rebounded pretty significantly. Whereas outpatient surgeries, in the outpatient section there, you got surgeries happening at both ambulatory surgery centers, ASCs, and hospitals, and those have declined, and particularly the hospital-based surgery, and they're still far below 2019 levels. And there's a few categories that are higher on this list, particularly if you go into the professional, you'll see other professional services is quite a bit higher in 2021 than it has been before. Some of these professional services, a lot of that has to do with COVID testing and COVID vaccinations. It turns out that a lot of the COVID vaccines are not administered in the primary care setting, and so it's just a little difficult for us capturing all of that with our standard methodology in terms of categorizing all that. But you've got a ton of COVID lab tests and a ton of vaccinations that are inflating some of the professional numbers. So I'm going to just let's go to the next slide. And if somebody has a question, go ahead. Somebody let me know or raise your hand or something. But we'll go to the next slide. And this is just a summary of some of the things that I just have mentioned. I just want to say that I go to the last bullet point there. There's several of those categories: laboratory, other primary care, other outpatient, and other professional. All that stuff is higher due to some of the preventive services involving COVID. Now, that's not readily apparent on the chart. You have to go into a little more detail on the chart, but I figured I'd limit you guys to just one eye chart per presentation. And so I called that out in the bullet points. I went and looked at that in more detail, but it's not displayed on the chart, so I put it in the bullet points. Okay, and then, and I didn't mention the vaccines. So vaccines are all brand name, and so that drives up the brand name utilization when you look at pharmacy spending, but really it's not that people are suddenly going out and buying brand name drugs, it's these vaccines. And so fortunately what you see there is a higher utilization of brand name drugs, but the vaccines are relatively lower cost, so that ends up having a lower cost per claim in the brand name section, which is fine. So just to explain, so what you're sort of seeing in the cost and utilization landscape. Now that's at a macro level, but I want to dive in because on the surface, you might get the idea that, okay, so we had relatively high utilization in 2019, and then it dipped way down in 2020, but now the pandemic's kind of mostly over in 2021, everything's sort of coming back and pent-up demand and all that. Well, let's dive into that hypothesis a little bit and see what we find. So let's go to the next slide. Oh, and I just wanted to mention, so one more about just the vaccination. So that was, so Pebb members generated about $800,000 in vaccination spending in the last 2 years. Totally worth it. As we all know, it just is really what saved us from having a lot more hospital expense. You can see a couple of things that I have on here. So on the bottom left is the line chart showing when those vaccines happen. You can see that the vast majority of that is in late 2020 and early 2021, and it's just really tapered off since then. People got vaccinated, and there's the utilization of boosters, et cetera, is just really not anywhere near the level of what it was when the vaccines first came out. It turns out that pretty much all vaccines have declined, and that's a symptom of what Yale and others have been mentioning before. Is just utilization has been depressed. So you can see, like for example, on the chart on the bottom right, where we have claims per thousand of all the different types of vaccines, you can see that all has continued to decline since 2019, and it might take a while for us to get back to vaccination rates that are similar. Lots of reasons for that. Possibly misinformation about vaccines and the fact that that's been politicized, and also just because primary care utilization has been a little bit depressed. So vaccines, that's the story there, and hopefully we'll watch that, and we'll find ways to through quality measures, et cetera, to motivate providers and through good information to motivate members to continue to get them. Right, but and I just wanted to put this up there, and so this explains to somewhat, like I was mentioning on the first page, why some of those professional costs have gone up in 2020 and 2021. All right, let's go one more slide. There we go. So this is kind of an interesting thing that we've seen, which has a lot of implications for the way we analyze data. And it's just the impact on the risk scores. So what you're looking at here is a chart of risk scores, two different types of risk scores for OEB and Pebb for the 3 years. And you can see where under those columns labeled retrospective risk, that risk score is based on diagnosis history and prescription drug fills, whereas the next group of columns, demographic risk, that's just based on your age and sex. And so you can see that the retrospective risk has declined, and we're seeing this across our book of business, whereas the demographic risk has not. So it's basically you have the same age of people, but they're appearing to be healthier as you go through the pandemic. So are they getting healthy? I mean, you can have a number of possible hypotheses. You know, I put the dislike button on there on people getting healthier during the pandemic. That seems very unlikely to me. What is more likely is that because office visit utilization is declining, that there's fewer opportunities to document the underlying risk, which is a little bit of a concern because of this idea that maybe people are deferring the care that they actually need and it's going to get worse later. It's also possible and likely that, as Dr. Popowich had mentioned, providers are burdened here and maybe they're just not having the time to document everything that they used to. And so that's just something that we have to be aware of when we're analyzing data by risk, is that particularly some of the members with conditions, the risk might be underreported. Okay, so let's keep going. And then I want to share this next section. This data, I combined OEB and Pebb data together. And this has absolutely nothing to do with the fact that we might have to do an OEB presentation later, and I didn't want to make two. That had no bearing on my decision to do it this way. I just want to assure you that. Anyway, OEB is, for mode at least, is much larger, and we really need a large data set to say something conclusive and credible about what COVID has done to the cost of specific COVID members. So we wanted to bring us a larger data set to this. So anyway, so this is going to be OEB plus Pebb, and we'll go to the next slide and I'll show you what we found when we started looking at this. So what we did is we tried to identify COVID members who had COVID. And then so on the left here, I got two charts here. On the left one, you see the count of members with a COVID diagnosis by year. So you can see there in 2021, we had a ton of members get COVID in 2021. This right here is going to be by calendar year. So the years are not set up in the same way that the charts before where I started the year in March. Anyway, so that's just a raw count of members. And then on the right, you can see when those members initially caught COVID. So we had the different variants for a while, alpha, beta, gamma, all the way up through almost the summer 2021. And then the Delta surge in the summer there, and then Omicron in late 2021, early 2022. You can see it was just a huge peak in cases. And so even like if you look at the chart on the left there with the green bars, the 2022 bar is lower than the 2021 bar, but it just got a gigantic peak because everyone got it all at the same time.
And Bill, just to confirm, when the numbers come into MODA, they get reported to OHA and the CDC, is that right? So these also reflect anyone who just reported to their healthcare provider. It also got reported overall.
Well, what these numbers represent is when I was able to find a diagnosis of COVID in the claim data. And so this will be underreported for sure because of the in-home testing that we're not going to have.
Okay. Yeah, I know. I understand the numbers are really underreported. And if MODA gets a claim diagnosis, do they also report it to where it's getting tracked with OHA and the CDC?
I think you're right about that. I'm, to be honest with you, I'm not 100% sure about, because I don't personally handle that, and I'm not 100% sure about how that works, but I do believe that you're correct about that. Okay. Well, let's go to the next slide. So, before we go to the next, I skipped over one part. What I wanted to do with this data is identify cohorts of who has COVID and who didn't have COVID. And so there are some people that got COVID more than once, but what I've just done is I created a list of all the members who got it at least once and picked the first time that they got it, and then put all those members in a cohort. And then the people who never had it documented in the claims record, I put those people in a second cohort. So if you go to the next slide, that's what the next slide is going to talk about. And so here, what you're looking at here is the per member per month spending on these COVID members for each year. And so if you look at the horizontal axis there, you can see it goes from -12 to +12. Those are the number of months since the member was first diagnosed with COVID. So the 0 month is the first month for that member that they had COVID in the claims record. And there's just, you could spend 20 minutes talking about this chart. There's a lot of interesting things. So first off, you see that in 2020, the cases were much more severe. So we had a lot of hospital spending, and it was over $4,000 during the first month on average for each member who got COVID. And then in each successive year, the cost, that cost peak decreased, probably as either the disease got more severe or people got better resistance to it, or any number of reasons. Perhaps the treatment is just delivered in a more efficient way. And so you have, so the peak is declining. But you also notice, look at the height of the series of lines to the left and to the right of that peak. So you can see that to the right, it doesn't go away right away after this first month. So the costs are elevated for several months after the first month where the person had COVID. It does appear when you get to the far end of to the right side, as you get to months 8, 9, 10, 11, 12, then you're starting to return to a pre-COVID level. And this is fascinating because, I mean, there's certainly been a lot of discussion about long COVID and the continuing implications of this. We're seeing that costs, for the most part, when you have COVID, they do on average return closer to the pre-COVID level than what you were thinking. Because keep in mind, this is for every member. So these are all different time periods. But in general, you know, the costs are maybe marginally elevated after 6 months to a year for somebody who got it. And we'll go, and I've got a few more slides that go into that in a little more detail. So let's go to the next one. So, and the next slide, this is just, this is the same data from that chart I just showed you, but it's summarized in tabular form for people who just don't like those graphs with trying to figure out what all that means. So I just summarized it there in a table for you, and some observations. And the observations are pretty much just what I just described, but I want to draw your attention to that chart on the right there. And so I've got some of that data just averaged and put the average PM there for you. And I just wanted to show you, so in the bottom 2 rows of that, so when you're 1 to 6 months past COVID, you're still pretty elevated in terms of your average cost. So it doesn't go away in the first month. It takes, you know, for the first 6 months, the average cost is still pretty high. But at month 7 to 12, it's really starting to drop back down to what you would consider a normal trend. And in each year on this chart, the percent of elevated level of cost, it goes down a little bit. So like in the 1 to 6 month, it starts 40% higher. And then the next year, it's only 27% higher. And then if you caught COVID in 22, it looks like it's only 18% higher. So the bottom right box on this chart, we don't know. So it's 2022 is still low, but are we gonna be back? If somebody caught COVID in 2022, are we gonna be back to like, you know, 3, 4, 5% trend after a year, which is essentially a normal trend? So that's a question, but it's sort of, I mean, if you just look at this data, it seems like certainly a plausible hypothesis. Let's go to the next slide. And I think the next one I have is on inpatient. And just in the interest of time, I'm just going to skip over this one. I think it's probably pretty obvious to everybody that inpatient hospital spending, yeah, it's a main driver. And then I just want to sort of circle back with this slide to the very first one I showed you, where we were saying, look, the cost was, you know, was relatively high in 2019, and then it dipped in 2020, and now it's, you know, coming roaring back in 2021. Well, that message in the aggregate is true, but when you really dive into it, it's just not really the initial hypothesis we have there just doesn't turn out to be right. If you look at the green line represents all the people who had COVID, and the blue one is everybody, and the pink one is the people who never had COVID. And it turns out that the pink line is continuing to go down. So it's not that utilization is coming roaring back for the people who just decided not to go to the hospital in 2020. Those people are still having a suppressed utilization over what we saw in 2019. And it's really the people who got COVID and all of their associated costs that are continuing to drive the trend higher. So we'll go to the next one. I'm going to just run through the last few quickly because I know I'm running out of time. But this is a similar thing where if you look at it's the same data from the chart I just showed you, but summarized in tabular form. And if you just look at the non-COVID members, the far right column of that, we're still significantly below the average per member per month spending on these people who didn't get COVID compared to where we were in 2019. So it's definitely not recovered. The real driver here is that the COVID costs have continued to inflate the trend in 2020 and 2021. So let's go. I think I'm almost done here. I think I might have. Oh yeah, and so here's my long COVID. Now we were really hoping to do to show you something on long COVID, but just turns out that this is not being documented in the medical record. 2.9% of all COVID members had a diagnosis in the claim record for long COVID, and just not very many. You can see that the green line there is Pebb, and there's just a handful of people who have that diagnosis. I think it's likely that this is just, it's not that people don't have long COVID, it's just that they're not, whatever their symptoms are, they're not going in and getting evaluated and having that diagnosis put on the claim. It's just too small of a population to get reliable numbers on what is the cost of long COVID. We're not able to do that because you can see just a few members. I mean, you can't do it. And even if you look at OEB and Pebb together, it's just, for 40, 50 members, the cost is going to be too variable there. I'm hopeful that as time goes on, we can get a better assessment of this. But one thing that if you combine this with the other data that I showed you a little bit ago on the spikes and what happens, how quickly does the cost recover? It means that long COVID is a cause for concern, but what we're seeing in the data now does not. It's indicating, okay, it's not killing us yet. Is basically what I can say. So let's go on. I think the next one's my last one. Go to one more slide. Yeah, and so what I was mentioning, so when I first started out, I said, oh yeah, you look at the overall cost and utilization data and maybe you'll think, okay, the worst is past, utilization has returned now and there's pent-up demand. Okay, that's not supported by the data anymore when you look at it based on who had COVID and who didn't. The revised theory might be, okay, utilization still a little bit lower than 2019 because people are just maybe not, they're not going to the doctor as much. And, but the costs for infected members are high. However, the severity appears to be going down. And so maybe, we get back to sort of a normalish levels. It's possible. I'm not going to say I think that's likely to happen. I'm just saying that the data suggests that that's a more reasonable theory of what's happened in terms of more reasonable than the initial theory you might get if you just look at the data at a high level. Okay, and I think there's a question.
Yeah, we've got a question from Sean. Go ahead.
Yeah, fascinating. So I think what this brings to attention, your slide just before this one, basically, that we don't have a great way of detecting long COVID. It has really vast implications, and I don't think that, well, I guess this is the question, like, in what ways can we start to detect those? Is there like a CDC-led process to get this? Because what I fear is going to happen is that all of these symptoms, which as you described are quite diverse, are just going to scatter into the four winds as everyone starts going to specialists. And the original cause being COVID, or at least it worsened, whatever it is that they're dealing with, will be lost. And so it'll just kind of generally look like there's an increase in costs across the board of specialists and whatever. But what's really happening is that there's like a package of consequences from COVID-19 that we're not really pulling together into a coherent look. And so do you have any thoughts about any kind of like federal special studies of that, or advice for insurers to to start coding this in a more coherent way for that detection?
That's a great question. I'll let Yale jump in. The only thing I would say to that is, is I completely agree with everything you're saying, and it seems like a problem that we don't have it captured in the claims data to the effect that we would like, and that's going to be a combination. It's going to be provider education and just general public awareness about what it is.
That's exactly what I was going to say, and it's a great point. There are great points that you made there, because we just don't know. We don't know why this is being reported in high numbers in some sources, and then when we actually look at the data, we just don't see it in our claims data yet. So I think a lot of it is going to be provider education. It's going to be public education about post-COVID. Maybe this is long COVID, and I do need to see my physician about it. And so that's going to be a lot of, like I said before, provider education and public education about what long COVID is and what to actually look out for.
All right, do we have any other questions from the board? All right, well, thank you, Dr. Popowich and Bill. And we are going to go ahead and move to the Providence presentation. And those who are following the agenda, we're a little bit behind, but we want to give Providence their time as we gave the other carriers. So, Dr. Gluckman, go ahead.
Yeah, thank you, Siobhan, and thank you for the opportunity to come here today. I think as you've heard from both Kaiser and Moda, this is a particularly challenging time in healthcare, and that providers on the front lines are stressed. There's strain on hospitals, there's strain on physician offices, and so as we are having dialogue with our provider partners, I think we really are trying to emphasize that in our mind to really make sure that we're treating people with the compassion that they deserve and to recognize what they're going through. We took today's time on the agenda to really take a hard look at whether the delays, those stressors that are occurring in the community and the delays in care that may be occurring are having an adverse outcome for Pebb members in terms of health outcomes. So we did a deep dive in a number of areas to say, are Pebb members suffering because of all these strains on the workforce? And that, I'm actually pretty pleased with what we're going to present, because it really demonstrates the commitment of frontline providers, their resiliency, and they really deserve our gratitude. So the first slide here is to demonstrate what's happening in some of the quality metrics for the Pebb population. Starting in 2021 on these hybrid measures, which is a combination of claims administration and chart review, we did some Pebb specific hybrid measures and compared them to benchmarks overall for the measures that we have performance targets, in our contract. And what you can see here is that in 2021, the colorectal cancer screening performance for the Pebb members in both the statewide and choice network were the 95th percentile overall. And in both of those areas, the provision of colon cancer screening for Pebb members is higher than our commercial average. For the metric for hemoglobin A1C of poor control, again in the choice plan, the performance is at the 95th percentile, and the statewide plan at the 75th percentile. The statewide percentile is not quite as good as our overall commercial book, which is in the 90th percentile, but still really strong performance. And what you can see here is that there was a decline in the level of control related to COVID in our overall commercial book of business, with some improvement from 2020 to 2021, but we're still not yet when it comes to diabetic poor control at the pre-pandemic levels. And that also holds true in terms of controlling hypertension, where there's also a slight decline. It was a little worse last year, getting a little bit better. But again, when it comes to the performance for Pebb, 90th percentile performance for Pebb Choice and 75th percentile performance for statewide. Interestingly, when we look at our overall book of business, and these are commercial overall, that's not Pebb specific because they're hybrid measures, and we targeted the hybrid, the specific chart reviews for the hybrid measures for the those quality metrics that we have performance metrics in the contract. But I think what you'll see here is that we've had a lot of emphasis on maintaining or improving immunization rates, and overall our immunization rates for childhood immunizations are higher than they were pre-pandemic in the pre-pandemic place, and as well as for adolescents. And we've also made progress in cervical cancer screening, where we're still at the 95th percentile. So I think we feel that whereas there's some concern around a little bit of a decreased control for diabetes and for hypertension, this compares very favorably still with the population at large, and we're starting to see some improvement compared to 2021. Next slide, please.
And real quick, can you just remind what HbA1c is?
Sure, it's a hemoglobin A1c, and it's a blood test that gives a sense of what's the level of blood sugar control over an extended period of time, like a 3-month period of time.
So that's the diabetes.
Correct.
Okay, thank you.
Correct. For breast cancer screening, we have a long history of actually fielding Pebb specific measures. And I think what you can see is that we've been able to maintain 90th percentile performance, although there's a little bit of a decline in mammography screening compared to the pre-pandemic period. But really on the modest side, and still really strong performance. And then another metric that we looked at that was a HEDIS metric was looking at preventable complications, which is a metric that's kind of a hybrid measure of chronic conditions that suffer like a hospitalization, and that could have been prevented by more intense care in the outpatient setting. And as you know, we've had some shift in the risk profiles between choice and statewide, whereas members who were historically in the statewide plan migrate over to the choice plan. There's been some shift in the risk. But I think the key number here to look at is the bottom number. The preventable complications per 1,000 is actually lower today than it was in the pre-pandemic phase. Now, I think we have to take a look at this and notice that dip in 2020, which is at the height of that. And people just really, there's a component of this metric that is also related to the fact that people deferred care and didn't necessarily go to the emergency room or go to a hospital and still did not suffer an adverse outcome. But at least we're not able to see that there is a decline or a worsening of preventable complications for the Pebb population. Next slide. One of the other metrics that we chose to look at was looking at whether or not, due to challenges with access and care, were patients in the Pebb population having more readmissions. I think that this is a little bit of a complicated metric in the sense that during the pandemic, elective surgeries were performed at a much lesser rate. Those procedures would tend to have lower complication rates, whereas the acute medical and the acute surgical admissions would still have been maintained. But what we're seeing is still very low levels of planned all-cause readmissions, a blip in 2020, a decline in 2021. If I compare this to our overall book of business, the Pebb performance is actually better. Pebb performance planned all-cause readmissions total is 3.5%. Our observed rate in our commercial book of business is about 4.1%. In trying to benchmark this, it's a little complicated because the metric is an observed versus expected ratio, which is then risk adjusted. And we performed overall in our plan at the 75th percentile. The Pebb numbers, what I think would be at least as good and possibly better, because the risk of the Pebb population is actually about 20% higher than our commercial population. I can't get you an exact number because it wouldn't be calculated at the specific cause of admission. But again, I think that what we're seeing here is that I'm not seeing serious adverse health outcomes for the Pebb population due to the challenges and the strains in the community on the workforce. Next slide, please. Next, we tried to look at, and again, I was really targeting cases that where there would have been a delay in care resulting in an adverse outcome. So we chose to look at admissions to the hospital that came in through the emergency room, so that we would try to cut out some of the noise about pent-up demand and say, okay, if patients couldn't get in and they had to be admitted through the emergency room, maybe that was a manifestation of both one, COVID, but also a manifestation of the fact that they had difficulty accessing care and their health deteriorated until they got to a more serious state. And again, I think what you see here is the top bar is the medical admissions decline from a blip in 2021 when people started to go to the emergency room again. But overall, the rate of admissions on the medical side is down through the emergency room as compared to the pre-pandemic phase. And if we look back on the surgical side, I think within the range of expected variation. Next slide. I'm going to just go through those. This is just the specific data for the choice plan, and the next slide is the specific data for the statewide plan. And I think in the interest of time, we're going to move through both of those so we can advance again. Go back one, please. Great. So another thing that we kind of chose to look at, go back one, please, or I think you have to go back two. Okay, now you need to go up one, sorry. Please advance the slide. One more. Okay. The next thing we wanted to look at is, okay, if patients were having difficulty accessing care in the community, could we identify some conditions or things that we're able to track that indicated that there was an adverse outcome? So we looked at admissions or emergency room visits for poorly controlled diabetes, and found that really no deterioration in terms of emergency room use or in terms of hospital admissions. So again, looking here, patients seem to be able to not get to such a severe state due to delays in care that they had to be admitted for poor diabetic control. And the next two slides just show the choice and statewide specific, and we'll just kind of go through those in the interest of time. The next thing we looked at, one more, and then I caught up. The next thing we looked at was looking at what can we learn about potential impact of the, one more slide, please, of delay in diagnosis for cancer. One more. There we go. All right, so this was a interesting and a complicated diagnosis. We were basically looking for, okay, I've already shown you that colon cancer screening actually went up. Breast cancer screening, a minimal decline, and cervical cancer screening, we're still at the 95th percentile, and that would expect to have some lag. There isn't the HEDIS metric, but I do know that lung cancer screening, which is historically underutilized, is still at reduced rates for our overall book of business and has not really rebounded yet to pre-pandemic levels. But what we've seen so far is that what I really looked for here was to see, could I find any evidence of late-stage cancer diagnoses popping up in the Pebb population? So we looked at our new cancer rates by tumor type, by whether there was evidence on the claim that they had spread, metastatic disease. And then we looked at whether or not people were treated with chemotherapy or radiation therapy within a 3 and 12-month look-back period. The idea thinking there is, could we find any evidence from claims, at least, about care that may have been have become regionally or metastatically advanced before a diagnosis was made? And this may just be too soon to say. We were not really able to see any evidence of increased rates of regionally advanced or local or systemic cancer based on treatment types. And then I actually asked Providence to take a look at their data, which would be their population data, including all lines of business and the uninsured. And the thing that we found there that is of some concern is that there does seem to be a delay in the timing of when a diagnosis of cancer is first made and when treatment first commenced. Whether that has an impact on health outcome or not, I think is uncertain, and to be honest, probably a bit unlikely, except for the stress that patients are under when they know they have a cancer diagnosis and can't get treated for a few weeks instead of a little bit sooner. So I think it's a little too soon to say what might transpire in terms of cancer incidence. The next set of slides, if you could advance the slide, please, has to do with our some deeper dives on substance use. So we've shared some information earlier about overall mental health utilization, and when we shared that information, we were able to kind of demonstrate that there's about a 20% increased incidence of mental health visits overall for behavioral health. But our facility use, our inpatient psychiatric utilization, and outpatient psychiatric utilization for facility-based, in other words, partial hospitalization and intensive outpatient care, was actually down. And as you know, we've implemented our telehealth behavioral health concierge platform. Pebb was the first employer that we implemented this for, and I know we're working to try to get more familiarization with the membership on this, because it is underutilized and we do have capacity to get earlier access. And in that contract, we actually have a 7-day access performance guarantee, which is pretty prompt for behavioral health. And that program has a patient satisfaction off the charts and Net Promoter Score of 82. But when we shared some of this information, Sean had asked for a little deeper dive about substance use, because we had noticed a decline in the use of substance use services. And so we chose to try to use that to see, could we find some evidence around negative impact for Pebb members for a delay in diagnosis. So this slide basically shows an overall decline in the utilization of substance use treatments, which kind of seems to be out of, disconnected from the reality on the population base that substance use disorder is occurring at a greater rate. So the first two little tiny bar graphs, and I have the raw data here, what we chose to look at here was, could we find evidence that patients were coming to the emergency room, were admitted to the hospital with overdose and intoxication, and did not find any increase for emergency room use for alcohol intoxication or substance use abuse or overdose. And then I also looked at whether there was any difference if it was placed on any part of the claim rather than just as the admitting diagnosis, and also did not find any evidence of adverse health outcome there. Bar graph in the middle, intensive outpatient therapy. I think the increases that you're seeing there are a reflection of how the delivery of healthcare has changed post-COVID. So you see a decline in the partial hospitalization as an example. Partial hospitalization is essentially a care model where patients don't require residential care, but get about 20 hours a week of contact care. And during the pandemic, that care was face-to-face and couldn't be delivered. So there was a shift towards more telehealth-based care, which would generally be done in an intensive outpatient program. That program tends to offer services of about 9 or 10 hours per week. And the increase in intensive outpatient care has persisted over time. I think, and interestingly, my behavioral health staff tell us that the ability for people to stay in treatment and adhere to therapy is greater in that treatment modality in intensive outpatient therapy, because they don't have to come back and forth, and the time commitment is more manageable for the rest of their life. So that actually is maybe an unintended consequence of a care advance related to COVID that we can learn from and build on for the future. So we're seeing persistent increases in intensive outpatient and less use of partial hospitalization, largely because the care has been found to be effective. When we look at professional services for substance use, we are seeing a little bit of a slight increase, but the numbers are still relatively low for patients who are treated, evaluated and treated just in the PCP, in the primary care physician setting. And then, we did have this quandary of seeing a decline in the utilization of behavioral health providers for substance use. And that obviously was of some concern to us. And can reflect the fact that there's challenges with supply. But that said, we'll continue to look hard to see if we're seeing any adverse outcome for Pebb members, and so far we haven't. And on the residential side, those are patients who were admitted and treated for a several week stay. Again, we did not see increases in the Pebb population. Next slide is just instead of utilization, you're going to next slide. There we go. Perfect. It is just on the total cost of care, and you can see that there is a bit of a blip in 2022 early. It's just the first 4 months of the year, and a little blip on the residential side for the first 4 months of the year, and that's something that we'll have to keep our eyes open for to see, is that a manifestation of just a buildup of substance use over time. But overall, as far as other medical complications of substance use, we're not seeing a major change right now, and we're not seeing an increased rate from what we can tell from claims on overdose or acute admissions for medical complications. Sorry, I got a call and interrupted. So the next slide is my last slide. And one of the other things we looked at was, could we see that anything about relapse rates from our data? Now, we looked specifically at the intensive outpatient treatment programs to see if the increase in utilization, as we talked about earlier, was there any evidence that wasn't effective? And in 2020, we did see this blip of readmissions during the height of the pandemic that has now come back down to historical levels. We also will take a harder look at relapse rates from what we can glean from the residential side or the partial hospitalization side. That's a more complicated analysis, because when a patient gets discharged from a residential treatment facility, they are often going to go into a partial hospitalization or intensive outpatient program. And when someone gets released from a partial hospitalization, they will often go into an intensive outpatient program. And the data wasn't clean, because that would be some of those that would be considered to be, relapses really aren't relapses. It's part of the continuum of care. And just in terms of the time frame that we had this, you can tell we did a lot of work on analytics, trying to give you a picture on a lot of conditions to see what the impact was on the health of the Pebb population. And that's just a little bit more complex, and something that we will look at to see if we can find that the shortage of services is having some other impact on health. And then I think that just in general, the answer for behavioral health is going to be growth in the telehealth space. It's not realistic to think that we're going to get an influx of providers in every corner in the state in Oregon, and we're going to have to look to rely on more centralized workforce to be able to provide care. And then obviously when patients need more intense services, to get that face-to-face care to them as close to their communities as we can. But we're going to need to do more in the telehealth space, and I think you'll be hearing more from us about that. We have some things in place now, and behavioral health concierge is one. But we are looking forward to implementing a very robust behavioral health telehealth solution for all of our members, because we think that's essential. So that's kind of what I was able to prepare for you. And Sean, you've got your hand up, and I guess you get to go first.
Thank you. Thanks for the presentation. Very interesting stuff. I think I mention this every time we start talking about it, but just for our future conversations about telehealth, just keeping our eye on the progress towards integration of behavioral health and physical health, being sure that we have a good screening and referral pathway through those telehealth touch points, so we don't lose, or we can continue to improve that kind of substance use, other types of screenings and referral, just to be sure that that's all getting absorbed into the system for the purposes of active management, and I know you guys are working on it, but just as we start continuing on those conversations, I know sometimes the solutions have to do with a third party vendor, and sometimes those vendors are not fully integrated. And so just keeping our eye on that and figuring out solutions for telehealth, and how to ensure that that it's all part of an active management system of people.
Yeah, let me comment on that, because I think that you raised a really important point. I want to assure you that part of the program on the behavioral health concierge program, it has that hardwired in. So I will say that as the program got started, we have given feedback when we look at the results that we think that the earlier identification for the patients who need medications. Now, this is, most of the patients in those programs are for depression and anxiety. So we do have a formal process where patients get escalated through our behavioral health hub into our navigation systems. And then when patients need prescribing and assessments made as to whether that's appropriate to be done in the primary care setting or whether we need a psychiatric prescriber. So I think that part of that is we have some structure. I think that earlier identification of who needs medications is something we've identified in that program. I think that your comments are insightful about when you're dealing with a national network. How do you bring that back into the community? So our behavioral health program, when we brought it in-house in 2021, we did do a strategic partnership with Beacon Health Solutions so we could have access to a national player with national carrier spread. But the care management team is local and is integrated in with our care management team. It's a unified team. So when we see patients getting services, we're able to actually get that into our care management team, into our physical health side, and then work on getting that coordinated in with their local providers, whether that's their primary care provider or when patients need more face-to-face service. I think it's a really important issue about how to integrate telehealth and just the general philosophy about how do you incorporate third-party vendors so that it's not completely disconnected. Because I'm actually hearing about this, not so much from our experience with providers, but providers are frustrated by all these point solutions that are completely disconnected from what they're doing. And so we're pretty intentional about trying to incorporate that work into the feedback we get we give providers. Our program with Verda, which is a program specific to poorly controlled diabetics, where it's not realistic in the PCP setting to be able to have the number of touch points you need to be able to contact and manage these folks, has a hardwired feedback loop into the primary care provider, so they're aware of what's going on when we more intensively manage those patients. Again, I would just point out that in the Pebb population, I think these programs are underutilized. And I think we're looking forward to a partnership. And Ali, and I've had a lot of dialogue about this, that we really need to try to intensify the marketing and provider education efforts. On this VERTA program, we will be going out to the provider offices, the PCP offices, with the specific members who are eligible and hoping to get better uptake. So we're working hard on that.
All right. Well, thank you, Dr. Gluckman. I want to make sure we get to any other questions from board members. We're a little bit behind on our agenda. So any other questions from our board members around the presentation? All right. Well, thank you so much for all of the information. We are going to have a 10-minute break right now. So if folks can come back at 11:15. Rob, did you have a question? Sorry.
No, it's just I was wishing I had more time in my committee during interim days, because I think some of the folks would find a lot of this just very interesting, like what's going on. But it's good stuff to know about, but it's not critically urgent, so I can't devote the time to it when I've got critically urgent things that I got to get covered in 2.5 hours in one day. I might get you up in the winter, Dr. Glickman.
Sounds good.
All right, so I'm going to make a note in our chat. We are on break until 11:15, and I'll see you all in 10 minutes. Thank you.
Thanks.
Welcome back, everyone. Emery, are you here?
Hi, yes.
Okay,
Jen, I am.
great.
Thanks.
We have Emery who will be presenting for us on the Risk Stabilization Fund. Go ahead, Emery.
Thanks. Yes, actually, before I start, I just want to confirm what time I should be targeting to finish. Should I be 11:35 or?
Ollie, I know you're here. Do you want to weigh in on that since we also have the open enrollment communications plan and then any public comment? What do you think? Ollie said he's having camera issues. Maybe he's having audio issues as well. Why don't we try to target 30 minutes?
Okay.
Oh,
sure.
Cindy, do you want to weigh in? Go ahead. Cindy? I'm not hearing you, Cindy. So I'm going to go ahead and let you get started, Emery, and why don't you go ahead and plan on 30 minutes?
No.
Okay. All right. Thank you.
Oh,
sorry.
Go ahead, Cindy.
I had to get off mute. Emery, just take as long as you need. I had talked to Ollie and let him know I can always do it next month. So if there's time, I'll cover it. If not, we're fine.
Okay. Thank you.
Right,
Go ahead, Emery.
Yeah, sure. Thanks. Thanks, Chair. So I'm here to present the Risk Stabilization Fund update. So if we move on to the next slide. The purpose of this report is to really take a look at the costs, current costs, and project out future costs, and then compare that against the potential future funding for Oregon Pebb, and to essentially show whether there's a chance of a loss in the stabilization fund when the cost might increase past your potential funding, and the impact on stabilization fund, and making sure that the Pebb plans are adequately funded for covering the medical services over the next few years. So what we do is we project the costs, and then we take a look at the funding based on enrollment and two different trend rates over the next few years. We'd look at what has happened over the most recent year, and so this Risk Stabilization Fund as of the end of December 2021, and then we take a look at restatement for 22, and then project out future years beyond that point. Why is this important? The Risk Stabilization Fund's used to really, if your costs increase above funding, it can be used to cover potential shortfalls. The stabilization fund, if you do have an excess, can be used to do things like cover wellness benefits, vaccine incentives. I think they've been used to offset contributions in the past. And what we try to do is we try to target a recommended amount to cover the potential fluctuations, and any amount above or below that would be surplus or deficit. And so we try to keep track of that surplus or deficit in this case. Historically, we've looked at fluctuations in Pebb costs and used Monte Carlo modeling to try to determine the potential fluctuations and potential losses, risk of loss for Pebb in terms of the fund and self-insured claims, and we translated that to a percentage of RBC that is being targeted, and then we show those results as well as the actual costs versus the funding for the most recent time period to kind of inform where Pebb is and whether you might need to make changes or reductions for future renewal cycles. Okay. Feel free to interrupt me if you have any questions, but moving on. So what is risk-based capital? This is just a kind of quick summary. So it's a way of measuring a minimum amount of capital needed to cover to be able to cover any liabilities. And so, as mentioned, we translate it to a percentage based on the RBC and AIC formulas. We'll show those in the future. It does provide a cushion against insolvencies, especially for insurance companies, and a lot of insurance companies are required to hold a minimum amount. Pebb is not necessarily an insurance company, but you kind of do operate, as self-insurance and just trying to make sure that there's enough funding, and you won't need to go back to the legislature or the state for additional funds in case claims do increase beyond what Pebb's funding is, or you are holding in your funds. And so what this cushion is focused on is really various areas of risk, which for Pebb is underwriting risk. Basically, if we move on to the next slide, is the risk that our projection of costs are actually, not, I guess, not accurate, or the costs do come in more than what our projected costs are. So when we do projected costs, we take base years of claims, 12 months of claims, and those are historical. So there is a little bit of a lag between when we, the claims base that we're using in the time period that we're projecting against. And then we apply underwriting trends, which include, and costs, which include trend rates. So the cost that services are going to increase, additional utilization. And then there's also other things like population risk changes. We've talked about risk scores in the past, and how risk scores increase every year, and that's a increase in cost to Pebb. There's legislation that happens, and we're coming out of a pandemic situation, and that which in the past we've talked about maybe the cost increasing quite a bit. As the earlier presentations showed, actually costs went down, and there's reduction in utilization and reduction in cost, and so that did impact Pebb. The question looking forward is, well, is there going to be return to services? And I think we heard some really interesting information about that in the prior presentations. But is there going to be an increase in cost in the futures, and how is that going to impact Pebb in that for that? And so that's potential areas of fluctuation. Also, large claims can impact Pebb. That hasn't been as big of an issue recently, but it has impacted Pebb in the past. Moving on to the next slide. So summary of the results. The depressed utilization due to COVID, we keep worrying that's going to bounce back. It has not really bounced back to the levels of where you were pre-pandemic. As a result, the fund balance has grown. So as we're looking at 22, our reprojection says we're expecting that there's going to be a surplus about $37 million for this year. That's makes the fund balance, stabilization fund balance, end at $364 million, and that does include the transfer penalty of $6.3 million. Reprojected 23 costs are actually as a result of the lower claims that haven't bounced back. We're actually saying that there's going to be a projected surplus next year of $33.4 million. Not all of that's due to the lower claims. Some of it's due to the funding assessment that was voted on by the board. So I think that's roughly about half of it, as well as some of the plan design changes. So right now there is going to be a projected surplus in the next year, which then also translates onto future years. Number 3. So what we took a look at here is the trend rates, and what we did was actually apply a little bit higher trend rates in this projection than we have been using for the underwriting cycle. So those results that you see up above do include the higher trend rates that are shown here. So for medical, we increased it to 5.75 from 5%. Pharmacy was kept the same, and dental just increased the trend to 3.5% from 3%. Part of this is due to just, I guess, a little bit of caution in terms of all the stories we've been hearing about staffing issues, people wanting to have higher reimbursements to cover some of the costs, their losses, stabilization of their, I guess, their businesses, hospitals, potentially losing money. Some of this is actually due to the prospective payment system from CMS. So for 23, earlier this month, the increase in the Medicare rate from CMS is actually 4.3% for facilities, hospitals. which is above the 3.4% that Pebb is limited to and higher than what has been in the past. So as a result of that increase for hospital prospective payment, potential rate increase, unit cost increases for next year, decide to incorporate some of that into the projections, into the trends here. So the trend rate did increase to 5.75 for these results. So 24 costs actually are projected still below the 3.4% increase in funding. So it looks like you're going to be in pretty decent shape, potentially going in, unless things change drastically for next year's renewal cycle. 25 costs do, though, end up above the 3.4% funding potential increase. And so the stabilization fund would then end at $385 million in 25, using these trend rates that I just mentioned above. Actually, any questions before I move on to the next slide?
Yeah, Ali, go ahead.
Yeah, thanks. Hopefully you can hear me now. So regarding what Emory said about the Medicare rate increase and just, I think some of the future increases that you'll see later in the presentation for 24, 25, that, we've recently spoken with the statewide cost growth target committee staff, and they've actually presented to you in the past, and actually Jeremy has talked about the work of the committee. And as you know, they adopted a 3.4% target, same as what Pebb and OWEB have. The difference being the adoption of a target versus the Pebb and OWEB 3.4% statutory cap. So when it comes to accountability, in some respects, the cost growth target program has more flexibility to make allowances for costs outside of providers' control. An example would be the Medicare increase in the Medicare rate. And some of what you heard today in our COVID presentations versus Pebb and OWEB with a hard 3.4% statutory cap. That same flexibility to make allowances or adjustments doesn't really exist. So because if we exceed 3.4%, we either have to fund it out of reserves or cut benefits. And currently there's no option to exceed the 3.4% and keep the benefits whole outside of using reserves. So the current target adopted by the committee is in place until 2026. If Pebb and OWEB were to get their statutes changed to be under the statewide cost growth target, it would take legislative action. So it's been put on the radar, our OHA legislative team and the cost growth target committee staff, and we'll just continue to keep you updated on any updates. So just wanted to mention that. Thanks.
Thanks, Ali. Was there anything you wanted to add on to that, Sean? I saw you came on camera.
No, that was well said.
And I just want to leave space, Greg, if you have any questions. I know this is something that we've been talking about for quite some time on the board and can be a little confusing for everyone to get their heads around. Go ahead, Representative Nos.
It's interesting how you all are able to keep under that trend when pretty much everybody else that I interact with is really struggling.
Yeah,
it could be that
Pebb has
it's less
been very
about
good.
insurance plans when I hear about the struggling, and it's more about the entities that have to provide care. Like the hospitals are blowing through all that because of staffing.
Yeah, Pebb has been pretty good at being able to keep under the 3.4% for many years. I think there's 1 year or 2 years where there have been some plan design changes, and there's been incremental plan design changes that have happened over the years, which has helped in the future. The Senate Bill 1067 definitely helped. The revisions to the Senate bill,
and that bill's kind of controversial in certain quarters. So yeah.
Yeah. And that's maybe directly impacting some of those hospitals that have been complaining or having financial issues.
I'm sure I'm gonna get some text messages here pretty soon. Okay, I'm going back on mute. Thank you.
Yeah. Okay.
Go ahead, Emory. Thanks.
Yeah. Any other questions, comments before I move on? Okay. So moving on to the next slide.
Oh, wait, Kate, did you? Oh, I thought you came off mute.
Well, it's either going to be a question on the last slide or this slide. So we can go through this slide first and then I can ask my question. So, because I know Emery's super shocked that I went ahead and peeked through all of some of these charts. So all of these charts. So
it's almost like numbers are your thing or something like that. Actually, moving on, let's just move to the next slide and then let Kate ask her question. Slide 6, please. Thank you. So what we show here is based on market trend rates. So these are the trend rates that Mercer has seen in the market and are using either in the renewal projections or in this case for this RBC projection, which are an increase versus what we use for the renewal. So the trend rates are listed there in the third bullet in bold. What we do is we take a look at the latest enrollment data. So that's June, and claims are also through June. And then we reproject 23, project out 24 and 25, as well as reprojecting out 22. And then we take a look at that versus the funding. And so this chart down below shows the projecting ending fund balance for 22 through 25. For 22, you can see in the purple line above the projected fund balance is well above the target. The pink line is really the reserve target, which is between the middle and the low, but then we provide a range in that blue box. But the purple line is well above the blue boxes or pink lines in all years. As you can see, the funding balance ends at 364 million. Is projected to end there in 22, increases to about almost 400 million in 23, and then kind of slight increase in 24 in the fund balance. And then you can see in 25, the purple line starts to dip where we're projecting out that costs are going to be increasing more than the funding. And so, I guess it's a good line for Pebb, especially the fact that the projected fund balance is increasing in 24 with market trends. So that does mean that right now we aren't projecting you need to make any cuts in plan design changes, but that's for now. So we'll see what happens if claims come back more, long COVID, other issues, cancers, other diabetes, and any, whether there's going to be a rebound in cost, which hasn't happened yet. And so 2025, the fund balance is projected to be $127 million above the reserve target in this case, which is about 50% or so more than where your reserve target is. And with that, I'll hand it over to Kate for a question.
Well, I see the representative's hand is still raised,
Okay.
and I don't know if representative
I don't
cool,
think it
just
came
making
down.
sure. Okay, got it. He'd popped up on my screen. So Emery, on the slide 5 of your presentation, you mentioned in the second bullet that there's a projected surplus of 33.4 million. But when I look at this next slide, slide 6, it's not the 33.4. Is that 33.4 more than what we had expected before? Is that what you're referring to? Because I don't understand where the 33.4 comes in here.
Yeah, the 33.4 is really the projected ending fund balance difference between 22 and 23. So
got it. Okay. Got it. Okay. And then when you're talking about the 5.575 medical trend, and then also are you doing that? Are you applying that to the 2023? So from like jump off point of 22 is all the way to 23, 24, and 25, or is that where you start applying the 5.75 and then whatnot?
Yeah. So the way the underwriting works, or the way that we project out costs, is we essentially redo what we do for the renewal cycle, which is to project out costs for 22. So we restate 22 costs, taking a look at the most recent claims, so 12 months through June of 22, and then project out the final 6 months. And then that does use this 5.75% trend for medical and then 10 for pharmacy. For 23, we take all of the plan design changes, we apply trend, we calculate out what we expect 23 to be based on all the final renewal decisions. And then 24 and 25 are essentially just kind of like trend increases, assumed trend increases on the 23 number.
Okay. And I'm always hesitant to increase that trend rate, especially for our Pebb population, because we have been pretty great about holding our cost growth, but I am hearing increased pressures for different reasons than what I've heard before. I will just acknowledge, I just want to note that here. I am hearing there's increased cost pressures, and they're kind of different than just pent up demand or, lower than expected utilization. It really is around cost increases, and it's not just pharmacy driven as much as I'm hearing anymore. And I'm curious, Emery, if that's where what you're hearing and why you talked to that little bit about that bump from 5 to 5.75, but I want to make sure I'm kind of articulating it correctly.
Yeah, I think it is really more underlying unit cost increases, the need to essentially get paid more for a particular service. Because I live out here in Bend, and St. Charles is one of the facilities that has had financial issues, and in addition to other facilities and stuff like that. But it is a really, we've been hearing, and we're actually having conversations with various plans, about the cost increases, about the cost pressures, and the contracting that's happening. And so it's a constant story. And so that's part of the reason for it. Part of it's really, CMS did increase what they're going to reimburse. So we wanted to account for that.
I just wanted to comment on that too. I just think it's something that we're going to have to watch when we look at the comparisons between the carriers and what the unit costs look like between them. And so I know we often, like today, it was helpful to hear from each of the carriers, but knowing what the trend is, comparing the carriers is always helpful.
And I apologize, but I'm going to have to jump. I'm 5 minutes late to another meeting, but I did want to kind of ask my question, so I apologize, but thank you, everyone. And text me if you need me back on for any reason. I can come back in about a half hour.
Thanks, Kate. We don't have any more votes, so I think you should be fine.
Excellent. Awesome. Thanks, everyone. Enjoy August.
Thanks. Okay. Moving on to the next slide. So this kind of just shows a comparison of the cost for 21 versus 22, and then 23, 24, and 25 projection. So in terms of the 21 actual costs that are coming in, the 22 reprojection that I mentioned using most recent claims and then projecting out the next 6 months. And then the 23 reprojection based on final renewal results. And you can see the costs are increasing. So for 21 to 22, the cost increased 3.3%. 21 did have that rebound from the depressed COVID utilization of 9% increases. And then you can compare that against the funding in the green bars. So the funding in 21 based on the census changes as well as Pebb board decisions only increased 0.6%. In 22 is increasing 2.9%, but then in 23 it's increasing 4.5%, which includes some of that funding assessment plus some savings from switching. So that 4.5% increase in funding is less than the 5.1% increase in cost, but since the costs are still below funding in 22, you're projected to have a surplus. And then 24, you can see the costs are projecting at 6.2%, which is the market trend compared to like a 4% cost funding increase in this case. So that 4% really because there has been about 0.6% switching or so in the most recent census in June versus what we used in March. And then for 25, the funding is expected to increase at the 3.4%, and then the costs are increasing at 6.2%. And that's where the blue bar is above the green bar. And then we're projecting that Pebb's going to run a bit of a deficit in that year, bringing down the stabilization fund. Moving to slide 8. Just another chart kind of just showing the cost increases and the historical. I guess this is really to Representative Nose's point about how Pebb has not really reached the 3.4% limitation in this case. You can see actually between 18 and 19, the cost increases were 3.4% in 19 and 18. It was above 6.3% in this case, but I'm trying to remember if that was actually a year with the premium tax or not. But anyway, but in any case, since 2018, you can see the green line, which would be a 3.4% trend growth. 2020, due to COVID, actually resulted in the 8% drop. Some bounce back in 21, but not enough to get back up to the trend. And you can see 22 and 23 trend rates are, I guess, 3.3 versus 3.4. You know, that's pretty close. And then 23 is a little bit higher, 5.1%, but hasn't quite reached that 3.4% continuous growth. And so this is really the story of Pebb Stabilization Fund, where the funding is, for the most part, been along the green lines, but the costs have been below. And so Stabilization Fund has been building up over years, in this case, especially thanks to the pandemic, I guess, really, in 22 or 2020. Next slide, please. So another look at this would be to take a look at cost growth of 3.4%. What we typically do is we use the reprojected 22 and 23 numbers, and then for 24 and 25, we could trend at 3.4% usually. But in this case, since the funding is going to be more than adequate to cover, I guess, market trends for 24, what we did here was to increase the cost to the market trends. So the numbers for 24 actually match what happens for on the prior slide using the market trends. And then in 25, keeping the funding at 3.4 and the cost at 3.4%, the projected ending fund balance actually just decreases just very slightly to 400 million. But you know, essentially it's flat compared to 24. So it's a little bit better story than what's shown on the slide, couple slides or 3 slides before, but it's generally the same story. You know, Pebb has right now some cushion in terms of being able to cover market trends versus the 3.4% limitation. Some of it may have to do with, you know, just additional funding or, I guess, buy down really of some of the increases through the Pebb funding, but doesn't look like you're going to be in a position again to have to make cuts unless something drastic changes in the next year or so. Next slide, please. So just some data assumptions methodology documentation here. As mentioned, it's through 22. It's trended, and there's some minor changes for adjustments for plan design changes and some minor COVID-19 impacts in enrollments 22. Talk about the trend rates there. And those were increases from prior analyses. The third one, payments out of the fund. This is kind of highlighted on some of the slides in the appendix. Didn't want to go through all the numbers, but we did include vaccine incentives that were paid for 22. Through July, it's about 0.6 million for incentive for boosters in that case. And then we have information on some of the surcharges that are being paid, as well as just mentioning the board decision on the funding assessment. And then just a little description of the projections in the fourth chevron, or actually, I don't know, trapezoid, the purple one there on the right. Let's see. Next slide, please. And then so we have the appendix here. Let's just move to the next slide just quickly in the 2 minutes I've left. So some of the numbers are shown here in terms of the projected costs as well as the funding, and then in the blue shaded, that's really surplus deficit for each year. So if you look at the second, which is essentially the middle column, the 2023 number, the projected surplus is 33.4 million. For 24, that surplus is about 10 million, and then you run a projected deficit of 23 million in the far right-hand column of 23 million. 25. And so the ending stabilization fund can be seen in the, I guess, green, light green per brown, I don't know, shaded column or row down at the bottom. And so in 25, it's about 385 million compared to the reserve target of 257 million. So that's about 49% above the target. And so this one's based on market trends. I think the next slide. is based on 3.4% cost growth. And that has the higher ending stabilization fund. And then the next two slides after that, I believe, just kind of show some of the detail behind the reserve targets. And with that, any final questions?
All right, I'm not hearing any more questions. Thanks so much, Emery.
Yep.
All right, I think I'm going to defer to you, Cindy, but it seems we have time for the communications report.
I think so. Can you hear me?
I can. Go ahead.
Okay. We are just going to cover, I had a few slides in here for some background information, but I think we just want to cover the open enrollment. So Rose, if you advance a couple slides. That one, that's perfect. So we are right in the middle of getting ready for open enrollment. As you know, it starts October 1st, and we are heavy into prep mode. This is just kind of a timeline of where we stand and what we're working on. We will do some webinars like we do every year. So those will be recorded, put on our on-demand page. Those are scheduled for, definitely we'll do one in October, and we may do one in September. The one in September usually is for agency admins, get them prepped and ready for open enrollment on their end, and then October is the member webinar. So we provide all of the information that they need. We will send out a sneak peek. So in other words, it's what's new in 2023 and a lot of other resource information. I show here that it's scheduled in August. We're actually prepping it in August, and it will go out September 1. And then later in September, we're going to send what we call an enrollment process and instructions email. It really gives a lot of detail of where people can go to access information, things they need to think about as far as health assessment, enrollment, all of the details related to that. The one thing that we do mail out is the summary of benefits, and we just are wrapping that up. The carriers are going to do a final review of it, but it's the side-by-side plan comparison that allows members to see what the benefits are and how they compare, all the plans compare with each other. So members have been telling us that they really like to have that in their hands, so that's something that we continue to mail to them each year. The target for that to be in their mailboxes at home would be like the third week of September, so they have it and can kind of review it before open enrollment starts on October 1st. So that is just about ready to go. We're also well along on the enrollment guide too. We work with Creative Services Plan Design. I can never think of the name of the agency, but they work with us each year and do just a really great job. They have Eli is the person who's working with us, and he has put together a lot of the guide now. The carriers have submitted their information for the guide, and we're just kind of finishing it up, sending him rates so he can get those insertive. We're trying to get this done. We've had some struggles in the past. We can get the English version out just fine in time for open enrollment and get it posted, but sometimes the Spanish version has been a little late. So we're really tried to move up the timeline this year so we can have both available on October 1. Mercer is going to work with us to put that into a ZMAG format. So when we post it, we'll have a PDF of the guide where people can actually print it out if they want to have a paper version, but also in ZMAG where they can flip to the table of contents and just click on where they want to go in the guide and go directly there. It's pretty cool. It's like a magazine. So that will be posted. So not many of us are in the office these days. We do still make posters available for people to put up around their offices if they are going to have staff in there, but they are self-print as they had been for the last few years since COVID. So those are going to be ready for a September date also, and we'll get those posted on the website so agencies can print them if they want. As often, or as always, we'll do some informational and reminder emails. This is always our biggest challenge. How many is enough, but not too many. And so, you know, we try to, it's a fine line. We do get feedback from members saying, I didn't know that, I didn't see that, to, geez, you're inundating us with emails. And so anyway, we're just trying to figure out the best route. We will have a couple that will go pre-open enrollment, as I mentioned. We will do some reminders throughout open enrollment. And I should say not just open enrollment, but also the HEM, so that reminding people to do their health assessment and the value of doing their health assessment and all of that. And then, of course, after open enrollment, we'll send some messages or some emails out. If you didn't get it done or you've changed your mind, you have some opportunity to correct most things, not all things. So there's a whole, I would have put them all on a slide for you, but there's way too many interactions that we have. So those are the most of the communications for open enrollment. But Rose, if you move to the next slide.
I have a quick question.
I did want to, oh, sure.
Yeah. So Cindy, when you were mentioning the webinars, are you partnering with Uplift? Since I know the Uplift ones are really focused in on new hires, but I would think this would be a time where we'd want everyone to join.
Actually, we have been working with them, and they are in the process, coincidentally, of creating some workshops for what they call non-new members. So I call us current members, but non-new members. And so exactly, we are working with them on that. So there will be more information on those. And I'm glad you brought that up. We'll make sure to get that information posted on the website and provide more information on that too. We just had a meeting on it yesterday.
Great, thanks.
Sure. So the last thing I just wanted to talk about is our virtual benefits fair. We had our first annual fair last year. It was very well received. This was kind of as a result of COVID and not being able to go out across the state and do the in-person fairs. So we worked with Mercer, and this will be our second fair. Construction's already underway. Actually, they created one for OWEB this year based on our Pebb one last year, so they're really in the swing. We should have it pretty well up and running here pretty soon. It's going to have all the same features that we would have in an in-person fair. So we'll have vendor partners participating. They'll have handouts. We do a giveaway for a random number of people. So the videos that carriers put together for our open enrollment presentation will be available in the fair. And we'll actually, rather than post the videos on our website this year, we're just going to direct people to the fair. The reason for that being there's so many more resources within the fair itself than we can actually share on our web pages. So we decided that was the best direction to go. So it's available during open enrollment, but we also keep it up all year long. So we do have a number of new hires throughout the year, and we want them to have the same available information. So it'll be out there posted all year long. I did put a link, which of course you can't click on here, to the fair for last year. So if you want to go in and take a look at it, it's pretty cool, has a lot of information in it. And I will be sure to let the board know when we are ready to go for the coming year. But Mercer is hard at work on it. So that was really all I had. Were there other questions, maybe?
You could add the link to the chat if you want us to look after the meeting.
Oh, okay. All right, I will.
Thanks, Cindy. Any questions folks have? All right. We are moving right along. I think we're back on schedule. And Ollie, are there any other updates?
No, for our boardroom in Kaiser, they've ordered the equipment. We don't have an ETA on implementation of the equipment. When it will go live, I think I've said I don't necessarily want to be the guinea pig, but they obviously have a lot of boards and committees that meet there. So it likely won't be before the September meeting. So that's kind of what we're looking at right now.
And we're also, I believe we said this in the last meeting, we're looking at a hold the date for a retreat, probably on the date of our November Pebb meeting. Is that right? So that's
Correct.
after
Yep.
the election. It's right around Veterans Day timing, or maybe the
Correct.
following
It'll
week.
be the same, day as the board meeting, and we may try and extend it a little bit depending on the agenda. But yeah, we'll be developing that in the next month.
And the plan is to do that in person, right?
Yes.
All right. So the last part of the agenda is any public comment. Rose, do we have anyone signed up for public comment?
No public comment.
All right. So Cindy shared the link in the chat. So if anyone wants to take a look, and we are officially done with our business today. So I'm going to adjourn our meeting. Thanks, everybody.
Thanks, everyone.
Bye, y'all. Good to see you.